Sure, sir.
So, good evening to everybody and thank you for checking in. My name is Dr. Ravi Nair. I'm coming as part of the Cyclops MedTech team. I'm an ENT surgeon of 1980s vintage, but with a long interest in vertigo. You have two expert panelists, Dr. Vishal Pawar, who is joining us from Dubai, which I hope is where you are, because Vishal travels extensively, so I'm not sure whether he's in Dubai or in the Arctic or wherever. You are in Dubai, right?
Yeah.
Dr. Surjit, who is an eminent otoneurologist from the Northeast, in fact, the go-to man in the Northeast, will be our second expert who will be inputting. Now, the topic for today is an extremely interesting case. The case would be presented by Dr. Kripa. We would have a small gap before she comes in. So till then, just to initiate the discussion, Dr. Sujit, when do you feel that a case which comes to you with vertigo is not classically an ENT case?
Well, there are a number of factors, but one of the first thing will be the first history itself. If the patient is not giving us a history of a true rotatory vertigo, then I tend to take, of course, a patient with bilateral vestibulopathy will not have true rotatory vertigo. Sense of imbalance is more common. A young patient coming with sense of imbalance more than vertigo, those patients are one of the first young patients with sense of imbalance, because bilateral vestibulopathy is more common in a little senior age group. Apart from that, associated factors are there. Severe headache and other CNS problems, or sometimes when it's not very typical. So they may have a typical, they may come with rotatory vertigo and give a very nice history of like position, which on history looks like a positional vertigo. But I do a Dix Hallpike or a supine roll, and the nystagmus is not textbook. So either there is no latency to it, or the nystagmus beat is not what it's supposed to be. Those are small things where I tend to really think of maybe this is not a little beyond my realm.
I'll put the same question to you, Vishal, as a neurologist. What would you say is the signs, symptoms to be flagged that this is not a case which is vestibular purely in origin?
So whenever a patient comes with a balance issue, so the first thing is earlier emphasis was on the basis of symptom, like what is the quality of symptom, whether it is vertigo, dizziness, imbalance, or vestibular visual symptom. The current this thing is approach is to approach it as a syndrome. Like try to divide the balance issue into three syndromes. One is acute vestibular syndrome. Second is episodic vestibular syndrome or a chronic vestibular syndrome. So if we divide it into this based on the history of the patient, natural history, how it is evolving. Suppose a patient has acute onset vertigo or imbalance, which is continuous from acute onset, as opposed to a patient who is getting episodic attacks of vertigo lasting for seconds, minutes, hours, but if they are subsiding. And the third chronic is it's insidious onset, gradually progressive, or it can be fluctuating every day, or it can be something like a static after some insult. So we have to divide it into these syndromes, three syndromes, and each syndrome has either central or peripheral causes. It is not that.
Evening, sir.
Yeah. Yeah. Hi.
Go on, Vishal. Go on. While you set up. Yeah, go on.
Yeah. So each of these syndromes, like acute, episodic, or chronic, has differential diagnosis which range from peripheral vestibular system to the central vestibular structures.
So my question would be, when do you feel that you would veer towards the central, or would you keep your mind open while analyzing?
Yeah, I keep my mind open. That is one. And if there are clear-cut neurological symptoms, clear-cut neurological signs on examination, and plus the VNG other testing shows that it is going towards like in favor of central neurological, central vestibular structure involvement. Then we have to label.
So my last question before we hand the mic over to Kripa is again directed at you, Dr. Vishal. When a patient comes with imbalance, do you commence with a neurological examination or do you commence with an otological or vestibular examination?
So whenever a patient comes, like I divide the examination based on the syndrome. I divided basically the examination in my practice into 4 parts. One is positional testing. Second is ocular motor system examination. Third is hints. And fourth is like this examination of cerebellar signs, all the neurological.
Okay, so you would do the neurological examination at the end of autoneurological workup. So you would that
no,
would be your sequence.
So what happens if a patient has episodic vestibular syndrome, which is triggered? Yeah. First, I proceed with positional testing.
Fair enough. No, I think so. As to summarize, we should keep both options open, and we should all develop our own methodology of approaching based on the patient load which comes to us. So that would be the consensus statement of our 2 experts on the panel. And now I invite Dr. Kripa to present this very interesting case. And we would, at the end of the case, come back to our 2 experts to take their inputs. And then, depending on the discussion, we would take in inputs from other experts. Dr. Kripa, over to you. You can commence and share your screen.
Thank you, sir. First of all, at the outset, I would like to say a very good evening to all, and especially to our esteemed panelists and Dr. Ravi Nair, sir. So is my screen visible?
Yeah, it is. I think you can go to full screen because right now we are seeing.
So is it done?
Yeah.
Okay. So yes, without wasting any further time, let's dive into the case. So this was a 54-year-old gentleman who presented to our center, and he noticed blurring of vision and vertical movements of the surrounding in the past 2 to 3 years, prominent in the past 1 year. This is also accompanied by an unsteady gait for more than 1 year, especially in dimly lit surroundings as well as on uneven ground. Symptoms began after a single first attack of severe vertigo that lasted less than 1 minute, and this was 3 years back. He denied having any tinnitus or headaches. There's no history of any urinary or bowel problems, and he took no medication during that period, although he was on his antihypertensive on and off, but no other medications apart from that. And there are no other auditory symptoms which were there in him. He was a known case of hypertension, as I just mentioned, but he was not on regular medications, very on and off, although when he presented to us, he was on Telma 40. No history of diabetes mellitus, tuberculosis in the past, bronchial asthma, or hyperlipidemia. So I moved on to the general examination, and the patient was conscious oriented, although we noticed an oscillation in his head. Gait looked normal. Physical examination, his vitals, pulse was 76 beats per minute, BP 130 by 82 millimeters of mercury in right arm sitting position. On local ENT examination, his oropharynx showed rhythmic oscillations of the soft palate, but rest of the ENT examination was normal. Moving on to his neurotological examination, we performed a head impulse, which was negative. On foam test, since he complained of a difficulty in walking also, there was generalized sway, which was noted. His head oscillations were noted. test of skew was negative, and cerebellar signs, finger nose test or dysdiadokinesia, everything was negative. The shin heel test, everything was negative. Cranial nerve examination was normal. All the cranial nerves were examined, and motor and sensory system examination was also normal in him. A VNG was done, and as you can see that in spontaneous and light only, we could note a very low amplitude vertical pendular nystagmus, which was of course enhanced in spontaneous and dark. This was noted in different positions of gaze, like upward, downward, followed by right, and then in the end, the left gaze. On high frequency head shake, the same pendular nystagmus continued. Although on hyperventilation, as you can see, the amplitude of the nystagmus increased post hyperventilation. On gaze testing without fixation, this is the same pendular nystagmus. You can see the sinusoidal waveform very mildly, which is more predominantly seen in the down gaze here. Moving on to his positional tests. Again, in Dixall-Pike right, we can see the sinusoidal waveform distinctly and better seen here. You can see that it is a synchronous waveforms, the conjugate nystagmus, almost in both the eyes, and eyes are moving synchronously in a sinusoidal waveform, and having both the sides, they're having slow phases. So that was the nystagmus which was noted. This is the video of a spontaneous and dark. Now, if you see very intently, you can notice a very faint, vertical nystagmus here, but obviously seen better by trained eyes. And on the spontaneous and dark, it was definitely enhanced. You can see better than the light. You can note a very minute, low amplitude vertical nystagmus, of course, interspersed with little natural eye movements. So this was his oropharyngeal picture, and you can note here that his palate is clearly vibrating with a very rhythmic oscillations upwards. So this was the palatal tremor, which was confirmed on oropharyngeal examination in him. This was his fundus picture, and moving on to the fundus video. This video was, this funduscopy rather was done by Dr. Srinivas sir. And the nystagmus, I want everybody to notice that the nystagmus which was seen now in VNG, or rather the naked eye, that was really difficult to make out by a beginner mainly, and also by a trained. But there was a little in his head, as I was saying, there was a oscillation, a yes type of oscillation. So if you do like this, he was like this, very low amplitude, but it was a yes type of oscillation which was noted. So when we look behind at the back of the eye here at the fundus, you can see very nicely the vertical oscillations in his fundus. This is the right fundus, followed by that is the left fundus. So both combined findings and a nice clinical picture gave of the ocular findings as well as the oropharyngeal findings clinched the diagnosis to be of an oculopalatal myoclonus. Although because he was complaining of oscillopsia and having difficulty walking in the dark or uneven ground. So this is many times also seen in bilateral vestibulopathy. So his history was confusing because of that. But of course, the 3 years back, the first severe attack of vertigo which happened probably could be due to the first hemorrhagic event that which happened in his brainstem. But of course, unfortunately, we don't have the MRI of that time also. And although we referred the patient after this to a neurologist, and the patient has again lost to follow-up, but we are working on that. So the differentials in this kind of case for any pendular nystagmus or acquired pendular nystagmus would be, it can be idiopathic, but most commonly it is seen in the disorders of the central myelin, that is multiple sclerosis, Cockayne syndrome, visual loss, in acute brainstem stroke, Alexander's disease being the more rare causes, neurosarcoidosis, Whipple's, which is intestine of the villi, which is a disease of the villi of the small intestine, where which leads to a malabsorption basically because of these redundant villi. And to mention a few rare causes would be hypoxic encephalopathy, sporadic cerebral ataxia, and serotonin syndrome. These are my references. And the take-home message, I would like to capsulate this case, if I have to tell you in 2 sentences, that is, every time we see such patients with synchronous tremors, say in the head, confirmed in the ocular examination or in the palate, so we should always think of or rather ask history of any previous episodes, number 1, or especially some episodes clenching or pointing to brainstem injuries. So that's a reminder for all of us to keep our eyes open in such cases, such unusual cases rather. And very simple and straightforward oropharyngeal examination clenched the diagnosis in this case, and of course, which was confirmed on fundus. So fundoscopy is, as we talk in most of our grand rounds, that is an important part and important examination of a vertigo clinic armamentarium. I would sincerely express my gratitude to Dr. Srinivas Durasala sir for navigating us very seamlessly through this uncommon case. So thank you so much.
Okay, thank you, Dr. Kripa. I think
you.
you've illustrated the case very well.
Thank you, sir.
Let's take it from here specifically. We take it to the next level of discussion. So let me start with Dr. Surajit. Dr. Surajit, if
shall I continue sharing the screen, or
no? I think you could come off and be prepared to come back on if we need.
Sure. Thank you.
Yeah. So let's start with Dr. Surajit. Surajit, if you were to see a case like this, what would be your plan of approach? Because obviously this is not a standard case. You have a patient with what I could only say was a titubation kind of movement. You have a patient who has vertical eye movements. And when you examine it, you're confirming that he has a vertical kind of nystagmus, which is basically preserved in all head positions. You do not have any provocative position, particularly to suggest that it is a vestibular in origin. I assume that my summary was correct. So Surajit, how would you approach such a case?
So if you remember the points that I had mentioned, when I do not think it is of a vestibular origin, this patient actually ticks almost all the boxes. He's a relatively younger age group, complaining more of a imbalance kind of a situation than a true rotatory vertigo. And a vestibular examination reveals a very atypical form of nystagmus, which again do not conform to all those typical peripheral cohorts that we find, latency and all those things. So with this kind of a thing, it is very apparent that the origin of this problem is not in the periphery. It's something beyond the periphery. So I think in this kind of a patient's, a thorough neurological examination is very much important, especially given the history, his previous history. As Dr. Krupa had mentioned, he has had a brain, I think, stroke or something, brain stroke a few years back. Yeah.
Yes, sir.
So
severe vertigo for less than a minute. 3 years back. Yes.
3 years back. So I think this patient literally ticks all this non-ENT causes of vertigo, where I will think of non-ENT causes in this.
The second question is, if you were to see, I assume that you would call it jerks in the palate, myoclonic kind of jerks in the palate. What other areas would you examine specifically for myoclonus? Would you look elsewhere, or would you do you have any protocol of examination, or you would let the neurologist assess that?
I would see, technically there are a lot of protocols, but in a practical approach, I would first want a neurologist to have a proper go at this patient, go for a
So-
thorough neurological or somebody who is in that field.
So let us then go to Vishal. So we ask Vishal, if you have a patient who has head titubation, vertical eye movements, and myoclonic movements in the palate, in your examination, where else will you go? I'm sorry to be conducting a viva here, but I'm just
No,
pushing
no
you all
worries.
in that direction.
Yeah, no worries. So, like whenever any neurological or any patient for that matter comes to especially it was a part of our neurology training. We divide the diagnosis into 4 types. There are 4 levels of diagnosis. The first level of diagnosis is functional diagnosis. Functional means what is the patient having currently functionally. For example, this patient is having oculopalatal myoclonus is the functional diagnosis. For example, another patient we will take, like somebody has a weakness on one half of the body, like hemiplegia. So that becomes the functional diagnosis in that patient. So coming back to the oculopalatal myoclonus, that is the functional diagnosis based on the history and examination. The second part of the diagnosis is anatomical diagnosis. Anatomical diagnosis means whenever we see any patient functionally, suppose the hemiplegia, the anatomically we try to see whether hemiplegia will mostly it will happen in the brain, supratentorial or infratentorial, if it is along with the facial nerve involvement. So that is the anatomical involvement. So in this case, why I'm giving about hemiplegia is because it will be easier to understand, and then I'm discussing about the case. So in case of oculopalatal tremor, the anatomical diagnosis lies into the Guillain-Mollore triangle. Like it starts from the dentate nucleus, which is in the cerebellum. Then in the in midbrain, the red nucleus is located in the contralateral side of the of the dentate nucleus, and the contralateral. We are talking in terms of the what is ipsilateral or contralateral to the dentate nucleus. So suppose our right-sided dentate nucleus, left-sided red nucleus, and the left-sided inferior olivary nucleus, which is located in the medulla oblongata. These 3 structures form a triangle. This triangle is called as Guillain-Mollore triangle. So anatomically, whenever you see a patient of oculopalatal myoclonus, the diagnosis lies in this triangle. So in this triangle, it can be either a midline lesion or it can be a lateral lesion. If the patient has a midline lesion, the patient will have symmetrical palatal movement and symmetrical vertical pendular nystagmus. And if the patient has a lateral lesion in this triangle, it will lead to asymmetry. But in this particular patient, we saw that it is a symmetric palatal tremor on both the sides. So mostly it is a midline lesion in the brainstem. Now coming to the physiological diagnosis, third part of the diagnosis is physiologically what is involved, which structures are involved in this triangle. So what happens is, see, the dentate nucleus is connected to the red nucleus through the superior cerebellar peduncle with the help of something called as dentatorubral tract. So this tract carries forward like dentatorubrothalamocortical pathway. It sends the dentate nucleus is nothing but a part of neocerebellum, which is involved in fine tuning of motor activity, like the pyramidal output, which is coming from the motor cortex and going down. It is not a fine motor, like it is a coarse motor activity. But the dentate nucleus tunes that activity through this particular tract, that is dentatorubrothalamocortical pathway. Now coming to the red nucleus, connection between the red nucleus and the inferior olivary nucleus, there is one tract which is called as central tegmental tract, which is a very important reticular tract which connects these structures and tries to control the tone of the inferior olivary nucleus. Now coming to the inferior olivary nucleus of one side, projects to the vestibular. Actually, it is connected mainly with the fastigial nucleus, and the it is connected. It collects the inputs which are coming from the proprioceptive inputs coming from the spinal cord. It collects the input coming from the red nucleus or higher centers, and it projects directly to the cerebellar cortex. It is directly in connection with the Purkinje fibers with the help of climbing fibers. It has the highest priority. If you look at the afferents of the cerebellum, there are two types of afferent. One is climbing fiber and something is called as Mosey fibers. The climbing fibers are the fibers which have highest priority, which are coming from inferior olivary nucleus, and directly they have one-to-one connection with the Purkinje cells in the cerebellar cortex. And all other tracts which are coming from brainstem or spinal cord or cerebral cortex, they are called as Mosey fibers, and they are crawling on these climbing fibers. So physiologically, either the lesion is in the dentatorubral tract or the central tegmental tract. Now coming to the etiology, as Dr. Krupa said, the etiologies of this problem could be either vascular etiology. In 80% of the patient, it is usually a vascular etiology, and 20% of the patient, it can be demyelination due to multiple sclerosis. It can be a trauma. It can be a tumor. It can be iatrogenic lesion. These are the other possibilities. And in the vascular lesion, the most commonly it can be due to hemorrhage as compared to the infarction. So this is the summary of the diagnosis. Like
at this point, may I ask Kripa to read out questions from the chat?
Sure, sir. So the first question we have from Yona Goda ma'am is no. So the first one is from Pooja Suyal. Did the patient complain of some abnormal palatal movements, or is it an objective finding? So it was an objective finding.
But did the patient complain also, or did he feel it? Or because in all these jerky movements, one is where the patient can feel it and one where the patient is insensate. Vishal, would you like to comment on that?
Yeah, so usually what happens in these patients, because the palatal movements are happening at a frequency of around 1 to 3 hertz, and even they start synchronizing their breaths to this movement because it is a part of oropharyngeal nasopharynx. So because it can, patients can become aware of it, because while brushing or while watching themselves, they can become aware, and themselves then they can be aware because it has a sensation. So, and some patients, because of involvement of some other muscles, like for example, in case of palate, it is involvement of tensor villi palatini muscle. But if it is levator villi palatini muscle, but if it is involvement of some other muscle like tensor villi palatini, it can lead to audible clicks. So the patient can himself or herself tell about this complaint, or it's very important, as Dr. Krupa in her summary slide take home message told, whenever you see a vertical pendular nystagmus, the first thing we should do is check the palate, because even there are patients who may not complain about this thing. There are patients who may not complain about this finding. If they are not aware of this finding, it's very important to check the palate.
So even this patient had not complained. His main thing was the vertical oscillops here.
No, but I think this is an important point, Vishal. You know, like you talk about otorenal syndromes, when you have ocular myoclonus, you should think of oropharyngeal myoclonus associated with it.
Yes.
So I think that's an important take-home message for everybody. Any myoclonic jerks in the eye, please look at the palate. As an extension, I don't know whether you would agree, I think myoclonus can occur anywhere in the body. So I think we could also look for myoclonic thing. Would you agree, Vishal, or would you think that's not common?
Yeah, so there are a variety of types of myoclonus. It can be a cortical myoclonus, it can be a brainstem myoclonus, cerebellar myoclonus, or it can be a spinal, even spinal cord pathologies can be too. But specifically, whenever you see a patient with ocular movements, best thing would be to check the palate, because maybe the other types of myoclonus may not have, but it's a part of examination. We have to conduct that examination. It's very important to check that.
So Kripa, go back to the chat and here list the questions.
Sure. So the next question is again by Dr. Pooja Suyal. When is skew deviation positive in central lesions is a question.
Yeah.
Surjit, if you want to take it, or can I go back to Vishal? It's your choice.
I think Vishal will be the right person to.
Vishal, go ahead.
Yeah. So normally when the eyes are maintained like in a primary gaze, there is no malalignment. They are equally placed, and there is no vertical malalignment of the eyes, either in a static condition or in dynamic condition when the patient is looking with one eye. So this happens mainly because of central otolithic pathways. See, the vestibular pathway is divided into peripheral vestibular pathway, which ends into the vestibular nucleus, and the central vestibular pathway starts from the vestibular nucleus. And the vestibular nucleus, once all the fibers come from the semicircular canals, utricle and saccule, what it does is it says, okay, these are the this is the pathway coming from semicircular canals. It sends the appropriately to the different structures, like for example the semicircular canal pathways and utricular pathways, they get segregated. See, that is the reason why whenever there is a peripheral lesion, there is a mixed variety of nystagmus. But once the sensation comes to the vestibular nucleus happens, segregation of all anterior canal pathways different, posterior canal pathway is different, the lateral canal pathway is different, and in that again the excitatory and inhibitory pathways are different. That's why the pure variety of nystagmus, why it is common in central, is mainly because there is a segregation of all the pathways. So the inputs which are coming from the utricle and saccule, which are going to the vestibular nucleus, these then from the vestibular nucleus they are going into the cerebellum, and there is direct vestibulocerebellar connection also without involving the vestibular nucleus. Whenever any lesion involves the central otolithic pathways, then the malalignment of the eyes happen, and then that leads to the skew deviation. And especially in the context of oculopalatal tremor or oculopalatal myoclonus, it may or may not involve the central otolithic connections, leading to associated skew deviation may be present or may not be present. So that's why Dr. Krupa, in her presentation, you can see there was no skew deviation. She was specifically mentioning that there was no skew deviation. And the importance of skew deviation in this patient is, if the skew deviation doesn't happen, then the vertical nystagmus will be symmetrical. But if the skew deviation is present, then there will be asymmetrical jerking of the especially the vertical nystagmus. The vertical pendular nystagmus will be asymmetric.
Go on to the next question. I think that's a brilliant answer, but it seems to me that the moment you see vertical nystagmus, you are definitely looking at a central pathology. One question which I would ask is, to what extent is visual acuity loss associated with these kind of nystagmus, or is the pendular nystagmus of visual acuity loss not like this?
So coming to the visual acuity, so it depends on whether it is congenital pendular or it is an acquired pendular nystagmus. Congenital means not exactly congenital, infantile. It can start in the infancy. So see, if it begins early age, what happens? There are a lot of compensatory strategies the patient will develop. Like they will try to see the anything in the null point. There will be a null point where the patient's vision is better, or the patient will try to converge. Convergence reduces the pendular nystagmus, but that is about infantile variety of congenital infantile variety of pendular. But the acquired variety of pendular nystagmus, it begins suddenly, and the brain doesn't get time to adapt. So it will lead to a more profound type of oculopsia, and or it will lead to a kind of hazy vision. And see, the patient, they don't read books, so it will be very difficult for the patients to describe this symptom. Even if it is oculopsia, they might end up telling it is double vision, or they can tell it as a different symptom, and it leads to definitely reduced visual acuity, because it is continuously the environment is shaking, so the fovea is not able to fixate properly. And that is the reason why the head tremor is trying to actually, they are with the VOR, exactly opposite VOR, they are actually trying to see properly. Whenever the eyes are moving, normally what is VOR? In VOR, what happens is when we move the head, the eyes do the compensatory movement. But here the eyes are moving, then the head is trying to do compensatory movements to have a clarity of vision.
So, I mean, uh, are we concluding that if there is visual acuity loss, you could have a similar syndrome with more pronounced symptoms?
Visual acuity loss will definitely, yeah, like in terms of you're saying like visual acuity loss will lead to more pronounced, yeah, definitely. Yes.
So I think that's an important differential we need to keep in mind for these. I don't know. Because to be very frank, I have not seen a case like this. I've read about it, but I've not seen a case like this. So just a corollary question: have you seen cases like this, Vishal, before?
Yeah, so during my residency, I have seen only one case of oculopalatal myoclonus, and there was a cavernous bleed in the past, and that patient presented later on. Actually, what happens in this condition is it is not an acute condition. It is a past insult which leads to this condition from ranging from 3 weeks to 4 years. Up to 4 years, the patient can develop this manifestation oculopalatal myoclonus after the initial insult. And in this particular patient also, the patient had vertigo, like episodic vertigo, one episode of vertigo. Maybe the patient had acute some bleed in that area or something. And honestly, we don't have the MRI to correlate, but mostly the patient had some acute insult, and which led to later on development of this condition.
Dr. Sujit, do you recall seeing a case like this?
So, not exactly like this, no.
Yeah, but
So I have had patients who have had vertical nystagmus induced during testing, but typically this kind of a case where the nystagmus was going on all throughout, no, sir.
so we are dealing with a very rare case. I think we have to take
Yes, sir.
whatever learning we can get from this case. Kripa, please go on to the other questions.
Sure, sir. So next question is by Yona Voda ma'am. Hello, ma'am. Welcome. And she says, hello to everybody. So happy to be here. In this case, we can see an early canvas syndrome query or Parkinson's or extrapyramidal pathology or genetic path. That is the question. So ma'am is basically asking, is it an early canvas or Parkinson's or extrapyramidal pathology or genetic pathway is affected?
Yeah. Go ahead, Vishal. You'll have to take this. We
Hi,
will all just be debating our heads when you talk about ruberal pathways and stuff like that. But go ahead.
Yeah, hi, Yona. I'm really happy to see you here and happy to interact you in this forum. Yes, your differential diagnosis list is exactly correct. Like, for example, any patient in this particular patient, the patient presented with onset, gradually progressive imbalance of gait and then head shaking and other things. So in any patient who has chronic imbalance, canvas is one of the etiology, but in that definitely it is, there will be a lot of, yeah. So patient will have cerebellar ataxia, vestibulopathy, and the patient will have severe manifestation. The age groups might differ, the age of presentation. For example, usually in case of this oculopalatal syndrome, usually they present in the 4th or 5th decade of life. Parkinson's, yes, but Parkinson's usually it will present with like one-sided symptoms. Ocular motor signs are not prominent in the early part of the presentation. Parkinson's will have more of a tremor in the hands, rest tremor. At rest, it will happen. On action, it will disappear. It will start asymmetrically on one side. They might have bradykinesia and other extrapyramidal features. Then extrapyramidal pathology, yes, they can present, and genetic pathology, as the patient presented late, usually genetic pathologies will start early in the age group. But of course, sporadic mutations can present in the late age group, especially genetic pathologies like spinocerebellar ataxias and all. But yeah, in this particular patient, specifically, the patient had specific signs. So it goes in favor of oculopalatal syndrome, and it has a specific boundary of like lesions and specific etiologies we can consider.
So just a counter question to her. Does she have experience with similar cases? I'm just trying to see what is the frequency of incidence of these cases. Kripa, could you pose that question? Is she online?
Yes. So you want me to post to everybody?
Sure, you can post to everybody to ask whether they have seen similar cases. We just to get an over, just so that everybody gets an idea of the frequency of such patients.
Yes, sir, sure.
But in the meanwhile, you could also ask about
The next
question. Yes.
Sure, sure, sir. So the next question is by Avinash Bijlani, sir. Hello, sir. Good evening. What if any is the role of red nucleus in eye movement? Can you elaborate?
Yeah.
Vishal, it's yours.
So, yeah, so basically a red nucleus, it has it has very unique structure. It is present in the midbrain, and usually the brainstem we divide into tectum, tegmentum, and the peduncles, and it is a part of tegmentum of the midbrain, and it is circular in shape, and it has rich iron content. That's why it looks red during the sections, and it is even in MRIs also in the sections, you can clear cut see the red nucleus and substantia nigra adjacent to the it. So what happens is red nucleus is a very prominent important structure in especially in monkeys, because it controls the flexor tone of the upper limbs and lower limbs, flexor muscle tone, which is needed for continuous hanging and doing activities. But evolutionary what has happened, because we have evolved from monkeys, so it is still there, and it has it is still it controls the flexor muscle tone. It receives the input which is coming from the cerebellum, dentatorubral tract, and the red nucleus sends two descending this thing. It is a deviation from your question. It is related to the eye movements, but it has major role in the flexor muscle tone with the help of medial and lateral rubrospinal tract. That was about the motor tone. But in terms of the eye movement, it has a very important role in control of initiation and generation of saccades. So what happens is the saccadic pathway. If we look at the saccadic pathway, the voluntary and reflexive saccadic pathway, what happens? There are two types of fibers which come from the frontal eye field and parietal eye field area. The parietal eye field area is mainly responsive for the reflexive saccades, and the frontal is needed for the voluntary saccades. And these pathways, there are two varieties of pathway. In general, for any motor pathway, there are two pathways called as direct pathway and indirect pathway. So direct pathway is nothing but to the PPRF, and it guides it to do the saccadic movement. But there is indirect pathway which goes through the basal ganglia circuitry, and even it goes to the after the basal ganglia circuitry, it goes to the superior colliculus. From the superior colliculus, it reaches to the red nucleus, and each one has a say. It decides what is happening everywhere, and in the decides the environmental schema and all the calculation computation of its own output. And then it has a role in deciding the output of the PPRF, because PPRF or these premotor nuclei will decide the saccade. They are the saccade generators. So red nucleus is PPRF? Paramedian pontine reticular formation, which is needed for for the burst cell. It is nothing but the burst cell for the excitatory burst neuron for the horizontal saccades. So basically, the red nucleus decides the it has a role in saccade initiation and generation. Yeah.
Right, you have drowned him in an ocean of information. I hope you have answered the question in that. Next question, which you can pose.
Yes,
have you run out of questions, or are there more?
So there are more questions. Did
Please.
the patient complain of tinnitus? This is asked by Dinia Kadir. No, madam. So as I've mentioned in the history, there was no tinnitus or any auditory symptoms. But
So I can
thank you.
ask one corollary question to Vishal. You have tensor tympani myoclonus. I've heard of that.
Yeah.
Is that part of the palatal myoclonus syndrome?
Yes. So what happens is like this particular syndrome, it can involve any branchial motor neurons, like centers controlling branchial motor structure. You know, in first year of anatomy, there we had this branchial motor arches. We learned
Pre and post traumatic and all that.
especially lower nerve. Yeah, it was very traumatic. But all the lower cranial nerves supply these branchial motor arches, and what happens is the inferior olivary nucleus hypertrophy can the spectrum of manifestations I will tell, like inferior olivary nucleus hypertrophy can it may not be associated with any of these manifestations like palatal or ocular myoclonus, or it can be associated with palatal myoclonus, or it can be associated with palatal with ocular myoclonus, which is present in this patient. And there are plus. It can get added if different muscle gets added. For example, levator vela palatini gets added, it is palatal myoclonus. Tensor vela palatini gets added, it will be a click, like the auditory clicks or tinnitus, audible click can be heard. Then if the other muscles like facial muscles get affected, some patients can have facial myoclonus, patient can have pharyngeal myoclonus, patient can have laryngeal myoclonus, diaphragmatic myoclonus, limb myoclonus. So see, it depends on the extent of involvement, like and neurology or any disease is all about spectrum. It's not about one patient, it's about spectrum. If we keep on seeing more and more patients, there is one series by Zhang et al. On 84 cases of oculopalatal myoclonus. So he has described so many varieties. Some patients were associated with limb myoclonus also, as Ravi Nair sir, you were asking me. So it can be a variety. Like sometimes you can see MRI finding without palatal myoclonus also. MRI can show the inferior olivary hypertrophy, but the patient can develop later on manifestations.
Okay, Papa, I think Iona said something about having seen 2 cases. Could you tell us all where she practices in the world? Because I don't know her. You appear to know her, so.
Yona, ma'am?
Yeah. So do you know where she practices, Vishal?
Yes, sir, Romania. Hello, ma'am. Good evening.
Good evening. Hello. Nice to see
Hi.
you. I'm so happy and
Same
so
here.
honored to see you and hear you. Unfortunately, I don't have a very good connection and a good internet, but I work in Romania, in Bucharest, and we see a lot of patients since 10, 12 years, and we check in this field of vestibular pathology, and we have a lot of tests. But what can I say? I started to see my first palatal tremor to 70, 80 years old old man who was a doctor. And I was so impressed because was a with dysarthria, and his wife asked us to try to manage this dysarthria, and I saw first time in my life this palatal tremor, and I started to check, and finally after 4 months she write to me that the final diagnosis was Alzheimer, but was not ataxia, was a little bit unsteadiness, but not real vestibular findings like nystagmus. But with nystagmus, not vertical, was a little bit horizontal. I found other 2 person who are younger, 50, 60, I don't know very well, but I remember that we asked about their pathology, no gentamicin, no tuberculostatic drugs, but they told us that the alcohol was chronic alcoholism. So I don't have a lot of experience.
I mean, thank you very much, but I think
Thank you, ma'am.
we are getting this feeling that worldwide nobody seems to have too many, except Vishal saying somebody published 70 cases. Must
So
be
82,
phenomenal.
sir. Jang et al. 82.
82, which is
Yes.
phenomenal.
Maybe
Great.
these ENT findings are very important to show and explain to a neurologist, because we feel that it's in their area, and a good evolution, to see their evolution is very important. What to say about the treatment? I would give some exercises for a good fixation. I think it's important to fix this oscillopsia. I work a lot with patients with bilateral areflexia, and what can I say that you start quickly, you can strengthen the oculomotor muscle through fixation exercises. Maybe we work a lot with rotatory chair with fixation in a horizontal way, but I think we can start also this in this position, or I think now that you can stay with the head like this and start to rotate rotatory ways to fix eyes in orbit, because it's important to help them to fix their eyes. The oscillopsia is very hard to.
So I think we could have a small discussion on that. Just can you just run through the other questions? I don't want people to feel left out.
Sure, sir.
Kripa, could you?
Sure, sir. So the last question.
Ayana, stay online. Ayana, please stay online. Go on.
So the last question by Pooja Suyal again is, what is the line of treatment? So madam wants to know the.
No, I think we could just go to the next step. We have to discuss
That is the last question.
Fair enough. So let's discuss the treatment now. I assume we have another 10 minutes to go. Is that the rough time frame?
Yes, sir.
I don't know.
Yes, sir.
Right.
It's
So
8:50.
both to Vishal and Surjit, considering the fact that, of course, you'll have variety of diagnosis in terms of etiology, considering the fact that the progression of the disease will alter things, how would you plan a treatment which is logical?
I'll go first.
Yeah.
So, of course, this is a little, as already mentioned, a little beyond my realm, more of a neurological condition. But yes, in this condition, this treatment line, I think, should be of, from my point of view, please correct me if I am wrong, is of 2 ways. One is, of course, treating the cause. So as Dr. Vishal has already mentioned, this is most probably a hemorrhagic, some hemorrhagic conditions, hemorrhagic accident in the central pathways. So trying to find out the cause and trying to take care of that. But since this patient has a history, as Dr. Vishal has also mentioned, these kind of symptoms tend to appear much later than the primary attack. So what we can do is the treatment protocol is more towards rehabilitation. So maybe start rehabilitation packages. I'm not very sure, as I have not seen many patients, but if I do see such, I try to focus more on rehabilitation in this patient.
Okay, fair enough. Vishal, what would you say?
Yeah, as Dr. Surjit said, first is treatment of etiology. But in this case, specifically in oculopalatal myoclonus, like if usually this lesion happens, the destructive pathology happens like few years or few months before, and then this irritative pathology starts. So irritative pathology, like this is of palatal myoclonus or the ocular. Ocular myoclonus can respond to gabapentin, and if the patient responds to gabapentin, it is really good drug for that. Then the patients can, we can give prisms for improving the vision. The prisms can help to reduce the, like improve the visual acuity. Then there are drugs
Could you
for
repeat that?
Prism.
You said gabapentin. What is the second thing you said?
The prism.
prism.
The eye correction.
Okay.
Eye correction. So that can be used for these patients with suffering from pendular nystagmus, that is leading to the oscillopsia.
How does
for,
that work? Could you explain? I would like to clarify that.
So what happens is the prisms, like it reduces, it causes the convergence. As I told, now the convergence helps into the while reducing it improves the visual acuity. Improves the visual acuity. Exact mechanism, to be honest, I will maybe I can
No, it's
share.
okay. I get the idea. I get the idea.
Yeah. Then the palatal myoclonus, it can respond to trihexyphenidyl. There are anticholinergic drugs which we use in tremors. In general, we use a lot of drugs many drugs in tremors, like benzodiazepines. We use trihexyphenidyl and anticholinergic drugs, benzexol or other. There are some drugs which we use in patients with even Parkinson's. We have tremors. So these drugs can be helpful in this patient, but as for like I don't have much experience, like only one patient I have seen during my my infancy, but like these patients can be like we can try anticholinergic drugs. Then the next level of treatment is botulism toxin injection, like Botox injection to the palate can reduce the rhythmic oscillations, and it can help for 3 to 6 months. And there are case reports of usage of DBS in this condition. Deep brain stimulation surgery can be used in intractable this condition. And then the next therapy, as like Dr. Surjit, Dr. Yona told, that rehabilitation for the oscillopsia, if especially the VOR pathways are involved and imbalance, the patient has imbalance, then the rehabilitation and therapy can help. But exactly which modalities of rehabilitation,
But
to be
a
honest,
question regarding progression of these conditions. Do they tend to progress, or does it tend to remain static or improve?
Yeah, so this the natural history of this patient is it remains like either static, or it doesn't improve over a period of time. The natural history is the patient keeps on suffering from this disorder, and we can try these medications, and it may not progress, but like it is, because 1 to 3 hertz frequency, it will keep on oscillating the palate or the pendular nystagmus.
So then rehabilitation has a very strong role.
Yes.
Yeah. I think there are two things we could ask Dr. Yoder to come back online, and I think there was a chat box message flash. Dina Kader wanted to share her experience. So we could do first Dr. Yona, and then Iona, please give us your treatment experience. One, you said rehabilitation. Anything else you have to offer?
What to say about rehabilitation? Should be very specific for this person, because he must work with vestibular therapist to improve his I think his walk and stability without eyes first, with closed eyes, to walk and to move his head in all position, but without eyes, without fixation, and then with fixating some dots or some targets. But in his case, I don't have a lot of experience to rehab vertical nystagmus. I work a lot with horizontal. But if we know that it's possible to have a good stability at the people by vestibular bilateral areflexic. So with oscillopsia, no nystagmus, with big oscillopsia, that means you can work and you can try in his way because he will feel what kind of exercise are better for him. So I think to stabilize the targets and to help him to fix and to have a good oculomotor muscles. But I think it's something long term because he's young, and we don't know for sure the pathology, the etiology, and his future. So I have a feeling that it's better to be checked with a lot of CTs and I don't know. I had a patient with bilateral areflexia and few crises of nystagmus, and everything was paraneoplastic. So I'm so afraid of these kind.
I think
ask
you know,
always
that's a
check.
No, that's a very important point you brought out. Metabolic paraneoplastics, those things tend to fall through the grid. So I think we should not forget the importance of a complete, thorough examination in case some other abnormalities pop up. Am I right, Vishal?
Yes, yeah.
I think Dr. Kader had something to offer her experience. Could you put her online, if possible? Dr. Dina Kader? I saw a message which came on chat.
Yes, sir.
Hi,
Yes, so,
everyone.
yeah. Dr. Dina Kader, are you with us right now? Please, can you
Yes,
start? Yes, sir.
hi, how are you? Hi, everyone. I'm with you, but I don't have video.
Fair enough. We can hear you
No
loud and clear.
problem.
Go
We
ahead.
can hear you, sir.
Well, which part of the world are you from, sir? I think you're muted.
Hi,
go ahead.
everyone.
Yeah. Where do
Do
you
you hear
practice,
me?
Dr. Kader?
Yeah, I'm from Iraq, from Kurdistan, from Iraq. Good afternoon, everyone.
Welcome.
Yeah. Actually, my little experience, about 10 years in general ENT, I had one case of palatal myoclonus, which actually a young female, about 19 years of age, but her chief complaint actually was tinnitus. Subjective tinnitus actually that made her to search for the reason for some answer, for some, let's say, some remedy to treat her tinnitus. But the problem was that no one was ready to listen to her, or let's say to take care of her, because tinnitus, most of the time it's objective, it's not subjective. But when I put the patient in a quiet room, I actually sat just beside the patient. I actually heard the clicks, just like muscles when clicking. That's what my experience is, that the most prominent point for ENT surgeons is that you will have a subjective tinnitus, which is actually a very nice presentation, and you'll not see it anywhere. Okay, no problem. After that, we send the patient for MRI, but there was no lesion. But we referred the patient to a neurologist, which actually, I think the being treated patient returned back, and she was happy to have no tinnitus, and asked for the treatment. She said that they did some sort of botulinum toxin injection to the palatal muscle. But I think a patient came after 1 year again with the tinnitus. I think it's of short duration, this Botox injection, just like in other uses in aesthetic surgery. I think it's of short duration, not a long duration.
No, so I think that's an interesting point, and I would like to take this to Dr. Vishal again. is palatal myoclonus as an independent entity more common than oculopalatal?
So whenever palatal myoclonus happens, the lesion is again in this triangle. So that's what, there is a spectrum of this disorder. So
But in
we,
terms of frequency, is palatal myoclonus more common, or does it tend to be associated with this? Because in which case that would be rare, in your experience. Because I recall seeing one case of
palatal,
palatal myoclonus also.
oculopalatal myoclonus, usually they happen in together, but there are other types of myarrhythmias. I have seen another type of myarrhythmia, oculomasticatory myarrhythmia. The patient had pendular nystagmus with grunting, like the mandibular, the masseter muscle was a continuous chewing type of movements, and that patient had Whipple's disease. So that two cases I have seen. One was in Dinanath Hospital and one was in Mumbai when I was in just low. So two cases of that myarrhythmia I have seen. But palatal, what happens? To be honest, maybe I might have missed cases, because in general, as an ENT surgeon, you tend to examine the palate in every patient. But it's very important that patients might be asymptomatic and they may not complain about it, and it's very important to check the palate. So the take-home message to me from this is any patient with eye movement, especially pendular throat examination, is very important to check for the palate.
So I think we have really pushed the boundaries of time.
Yes.
So
Are we
I
ready
have
to
one
extricate,
question.
or is there anybody who wants to raise an important point or question? We are open to that.
So Dr. Pratishta Sachan is right now with
Yes,
us.
ma'am.
She is
Yes, ma'am.
requesting to ask a last question. May,
Yes,
may I
ma'am.
allow, sir?
Yeah.
Yes, ma'am. Good evening, ma'am.
Yes. Good evening, ma'am. There is one patient around the 70-80 years old female. She has continued chewing activity. She is not able to control that chewing activity. So, sir, Vishal Pawar sir, what we can do in that case? What we will do? Like, she has don't have any other complaint. There is no nystagmus and the other complaints, oscillopsia, nothing else. She has only complained that she's not able to control the chewing activity.
Chewing.
Yeah, chewing. So that's a complaint about that.
So,
There is a
major complaint is the chewing, like continuous chewing, or the masseter contractions.
masseter contraction and complaint regarding that there is a pain in masseter region. So I just give her some muscle relaxant. I cannot able to give anything else to her, but she not able to control that. When she awake, then just start chewing.
So, yeah, that is very important. Is it happening in the daytime or in the nighttime? Because nighttime, if it happens, it is called bruxism. And if it is daytime happening, then we have to think of this, even this myarrhythmia I was talking about, that can happen because of Whipple's disease, or there are certain other specific etiologies which involve the brainstem, which can lead to this. Or it can be just dystonia of these muscles, and anticholinergics can help. And there are certain types of jaw prosthesis which can help in these patients. Like there are certain dental prosthesis which can help to relieve this spasm. Actually, the jaw prosthesis can reduce the spasm of these muscles. They have to wear in the nighttime or even the daytime they can wear, and it can reduce these muscular contractions.
I think we could always connect you all offline, but I think for the purpose of this Vertigo Grand Round, I really must thank everybody who was involved in this, ranging from Vishnu, who did the back end, to the Cyclops MedTech team, which runs this program, to Srinivas, whose case this was at the first. And I really miss his experience and guidance today. To the two experts, Dr. Vishal and Dr. Surjit, I think you opened our eyes. To Kripa for having worked up this case. And I think for everybody from all over the world who have done us a great honor of attending. And we hope that we will keep this up. We are considering bringing out a small compendium of all these grand rounds so that people who have missed it can still access it, at least in an ebook format, so that the knowledge sharing which goes on through the medium of these kind of grand rounds continue. So thank you all very much. Dr. Kripa, you could say a few words and enable everybody to leave this. Good night and thank you.
Thank you, everyone, especially the experts, to guide us so generously about this uncommon case. I can just say thank you and be grateful. Yeah. So on that note, I would like to say a good night and have a great weekend, everybody.
Thank you, and good night to all of you.
Thank you, sir.
Thank you.
Bye. Thank you.